Thank you. We're going to be talking today about orthogeriatric care. So let me see if I can get this started. Okay. So thank you very much for joining Orthogeriatrics. I'm not sure if it's a term that you've heard before, but by the end of today's session, I hope you're going to be very familiar with it. And we're going to go through what exactly it is. How do we go about it from a practical perspective? What is the evidence base behind it? And kind of really thinking about how we'll be able to implement in the centers that you work in. So with every good geriatric talk, we always need to start with what our population is looking like in Canada. And I think in Canada, like very many other countries in the world, we're seeing an exponential rise in our older population. So this is data from CIHI back in 2013 to 2018. And that older population is going to be the largest growing population within Canada. And we're going to be seeing a doubling of our 75 plus age group over the next few years, certainly within my career lifetime as well. And the relevance for this in hip fracture is that hip fracture tends to be a condition that affects older adults. So anybody who works on an orthopedic floor, has worked with this patient population, will be familiar that it's very rare to see a patient under the age of 65 who has a fragility fracture of the hip. And usually if they do, there's a clear other pathological process taking place. This is some epidemiological work that was done in the 1990s. And at that point, it was very clear that across the world, we're going to be seeing an increase and doubling. And in some areas, like in Southeast Asia, much more than doubling in the number of hip fracture patients that we're going to be seeing and having to take care of. And if we are not proactive in the care that we provide, we're going to really run into some trouble. In Canada and specifically in Ontario, there's been a lot of work being done over the last few decades. I want to give a shout out to Osteoporosis Canada and the Ontario Osteoporosis Strategy, who have been doing an incredible amount of work looking at capturing the fracture, ensuring that patients who've suffered a fragility fracture are started on secondary prevention to try and prevent that second fracture or next fracture from happening. And we can see here that it's effective in that the rate of hip fractures that are occurring is going down over time. But because of the sheer increase in numbers of patients in that older age group, we're seeing the absolute numbers of patients arriving in our emergency departments in our hospitals with hip fracture continue to rise. And I would imagine that if this work had not been done, this line would be much steeper in its upward trajectory. Hip fracture consequences are not insignificant. If you've ever worked with patients with hip fracture, you'll know the journey, the struggle that they have to go through to try and rehabilitate and get through that acute fracture. Many of patients may not get back to their pre-morbid level of mobility and function. It is a high cause of patients needing to be admitted into long-term care, and the mortality rates are quite high as well. Here it's quoted at 23% at 1 year for women, and unfortunately with men, the mortality rates are even higher at up to 30% at 1 year. And the economic costs are not small either. So even back in 2010, we were estimated at costing $2.3 billion to the Canadian government per year. I'm sure that cost has gone up much higher. Patients who require admission to long-term care cost double what it costs for patients who are able to return home and into the community. So with that, not only is it important for us to look after our hip fracture patients well from a patient-centered perspective, from a patient experience perspective, it's also more cost-effective to look after patients well than it is to look after them badly. Which takes us back to orthogeriatric care. So what is it exactly? So this was initially coined in the 1960s back in the UK, where you had an orthopedic surgeon who realized that he was really great at doing orthopedic care, but not necessarily skilled or expertise in looking after older patients. But he had a geriatrician colleague just down the corridor who couldn't necessarily perform all the orthopedic procedures, but was really great at looking after older people. So together they came together and developed a shared care model. And essentially, it's looking at an integrated multidisciplinary management of older persons with a fracture, using evidence-informed pathways from admission to return to the community, which is the aim, and to maximize the quality of care and patient outcomes within the resources available. Now, often when we talk about orthogeriatric care, this is something that we want to do across the world. Like, everybody deserves good quality hip fracture care, but we do need to recognize that from country to country, from institution to institution, the resources that you have available to you, be it human, financial, physical resources, may differ, which is why we all need to be able to tailor this to our own institutions. So why are we focusing on hip fracture rather than any other type of surgical patient or other types of fracture? Hip fracture patients, because the majority of them happen in older adults over the age of 65, and often they're 70s, 80s, 90s, or hundreds, these are your typical geriatric patients. They have many of the geriatric syndromes. They're not young and robust, and they don't bounce back quickly. So the average age of a hip fracture is 83, and there's a high prevalence of frailty as well. 20% of patients are with hip fracture coming in from residential care, whether that's retirement home or long-term care, and is actually the commonest cause of admission to hospital from long-term care. There is prevalent dementia. So some of the studies have suggested that about 20% of patients are known to have dementia, and nearly 50% of patients have a degree of cognitive impairment. So they may have undiagnosed MCI or dementia. And the vast majority of patients, 95+% of patients, are falling, and the hip fracture may actually be a symptom or consequence of the underlying problem, which is that they are falling due to multiple reasons, and that needs to be looked into and not neglected as well. So this is what the orthogeriatric care model looks like. And, our hip fracture patients go through a really complex patient journey. And orthogeriatrics involves moving from a silo to a system where we need to work together as a team across the entire continuum of the patient journey. So if we think about these patients here, we have the patients hitting the emergency room. They see the physicians there and all of the healthcare members there. They then need to meet anesthesia, internal medicine, sometimes through their preoperative assessment, and then they are cared for by the orthosurgeons. And then post-operatively, they'll see their internist, their geriatrician, could be a hospitalist, their entire interdisciplinary team. And then through rehabilitation, which may occur in the acute care setting, rehab hospital setting, or in the community as well. Their primary care practitioner will be involved, and allied health. And also throughout the journey, everywhere, you're going to have all of our amazing nursing staff, our pharmacists, access and flow, and our administrative leaders as well. So while often the orthopedic surgeon may have their name as the MRP looking after this patient, clearly there's more than one person looking after this patient. And it's much better to have a cohesive system where everybody is talking to each other, because without those pathways in place, it's very difficult to provide seamless patient care. So what does orthogeriatric care look like, having everybody work together? There's three main models that have been described, and this is compared to standard of care. So standard of care would be what we call a reactive model, and that is, where an orthopedic surgeon is the MRP, and all the other services are consulted ad hoc or as and when required, specifically around geriatric care as well. So that's what we would often see. A patient is admitted, and geriatrics or internal medicine are only consulted like perhaps further on post-op day 10, when the patient is very delirious and we're not able to get on top of that, or they're not progressing as quickly as they should be, or now they've gone into heart failure, or now they developed atrial fibrillation, etc. So your first model of care is where you have the orthopedic surgeon as the MRP, and they are leading the team, but geriatrics is coming in systematically, automatically, proactively in a consultative model. The second model is where the patient is admitted, the orthopedics do the surgery, and they are rapidly transferred under the care of a hospitalist, geriatrician, internist, specialist rehab unit, and the orthopedic surgeon is then providing the consultation, and is no longer MRP. And the third model is to have a true shared care orthopedic geriatric co-management system where the geriatrician is fully integrated into the interdisciplinary team. So if you look at the literature, it's not clear if there's one model that's better than the other. It really depends on the situation you have in your own institution, but it's very clear that any of these models is superior to that reactive model. So I wanted to go into what I call the oldies but goodies. But so this is a really classic study looking at delirium and hip fracture. And I really quite like the way that this study was designed. So these patients with hip fracture were either randomized to standard of care, which is that reactive model that I mentioned, or a geriatric intervention. And in the geriatric intervention, the patients were seen every day by a geriatrician following these 10 this module of 10. So these were the things that were assessed every single day by the geriatrician, and they intervened as necessary. And I'm not going to read them all out to you, but I would hope that you can see that like none of this is rocket science. This is not some, amazing, really expensive drug. This is making sure that patients are getting adequate standards of care. They're getting enough oxygen. Their electrolytes are in place. Their pain is well controlled. Their bladder and bowel is working. We're feeding them. They're getting enough nutrition in. We're getting them up and moving, and we're proactively watching for delirium. And if we start to see evidence of delirium, then one, we're trying to prevent it, but if we see it, we're able to treat it quickly and appropriately. And just using these very simple interventions, what they found was that it reduced in a 1/3 reduction in the incidence of delirium in the intervention group. And of the patients who did actually develop delirium, there was a 60% reduction in what they called a severe delirium. So the outcomes from that perspective were much better. And with regards to number needed to treat, only 5.6 patients needed to be seen to reduce one case of delirium. So these interventions are really quite effective. And why is it important to reduce delirium? Well, it's not particularly pleasant for the patients, but we also know that delirium is independently associated with poor functional recovery at 1 month. So when we look at decline in activities of daily living, decline in ambulation, and outcomes like either death or having to be discharged to a long-term care home, there's a dose-dependent response. So patients who do not develop any delirium are the ones who are most likely to have positive functional outcomes or most likely to go home. Patients who have delirium but resolve at some point during their admission, they don't do quite as well as the patients who didn't develop any delirium, but they do a bit better. But the ones who have persistent delirium, particularly the ones who are persistently delirious at 1 month after their hip fracture, these are the ones who are most likely to have poor outcomes. So what we really want to do is try and nip it in the bud and be able to treat, recognize early and treat appropriately as well. Orthogeriatrics has been extensively studied over several decades now, and there have been multiple systematic reviews and meta-analysis, and this is one of the more recent ones. What it has shown is that there is definite reductions in length of stay. You have reductions in mortality, both in hospital and at 1 year. As we talked about, then there's reductions in delirium as well. Things like functional outcome have been a little bit more difficult just from the orthogeriatric piece to tease out because there's a lot of heterogeneity, because the way each unit is set up may be a little bit different from others because of the resources that are involved. But we are going to be talking more about function, and that's why we have Trish Dixon with us, who represents the Rehab Care Alliance. Orthogeriatrics has been implemented across the globe, and I would say that in some countries it is standard of care. So particularly in the United Kingdom, they're the ones who started it. If you go into any hospital across the country, you will have joint orthopedic geriatric care with an interdisciplinary team around them. And the reason why they have been able to do that is because they are single payer healthcare system, which is regulated by the government. And as much as we think in Canada, we are like that, we are not actually a single healthcare system. We're actually 10 provincial and 3 territorial healthcare systems, which may have differences in priorities across the provinces. So in a way that we are not quite as far ahead as some of our other colleagues across the world, but we're trying to change that. So in Ontario, initially Health Quality Ontario, now Ontario Health, have published these 15 quality statements on optimal care for patients with hip fractures. And a lot of these quality statements are based on the work that has been done through the United Kingdom. So if you look at the NICE guidelines, the SIGN guidelines from Scotland, I'm not going to say that they're being transposed, but they are very, very similar. But also need to think about the Canadian context as well. So while in the United Kingdom, it's very easy for them to say, well, every single hip fracture patient needs to be seen by a geriatrician. Geriatrics is actually the largest internal medical subspecialty in that country. Whereas here in Canada, we are probably one of the smallest. We only have 300 geriatricians across the country. So, and we are much larger geographically as well. So I think it would be naive of us to say that every single patient should be seen by a geriatrician, but it may not be impossible to say everybody should be seen by a clinician who is familiar with geriatric principles. So if you see all the way from quality standard 1, when patients hit the emergency department, through to pain management, intraoperative management, postoperative management, delirium screening, rehabilitation, and secondary prevention. This really does follow the entire orthogeriatric care model that we spoke of earlier. So because we have multiple different provincial and territorial healthcare systems, 2 years ago now, we did publish a position paper, which is meant to be a Canadian-wide orthogeriatric position paper. And it really does outline many of the same principles that we see in the Health Quality Ontario work, but you can go to your organization if you're outside of Ontario and say, this is what is recommended Canada-wide. I have posted this paper and the quality standards in the contents if you'd like to read it afterwards. This particular paper was designed to make it very practical and almost like a step-by-step guide for units who want to try and implement interdisciplinary care on what the things that you need to consider and how to go about it. So this is just an example of what we did at London Health Sciences Centre, which was an initiative that was led by one of our orthopedic surgeons, Emma Shemich. And what happens if we are actually able to implement the quality standards and this interdisciplinary care. So in London, we have 2 hospitals. We have Victoria Hospital in the south, and we have University Hospital in the north, and we have very similar numbers of hip fractures at both sites. So we had an integrated orthogeriatric hip fracture model at Victoria and standard of care at University Hospital. And our findings, which are outlined here on the right, is very much reflective of what we see in the literature, in the orthogeriatric literature, with regards to reduction in inpatient mortality, reduction in length of stay, reduction in delirium rates, improved patient-centered outcomes like reduction in pressure care. And if we can achieve all of those, it will translate into cost savings. So as I said, it's not only better to provide good quality care to patients, it's also less expensive in the long run to provide good quality care also. So that's really easy for me to say, but how do we actually implement this? And what are the things that we need to think of? So this is a survey that we did amongst geriatricians through the Canadian Geriatric Society a couple of years ago, asking about facilitators and barriers at their individual institutions. And the 3 strongest things that they found was the things that really pushed establishment of a program by far and away is clinical leadership. So thank you all for being here today, because just by being here and wanting to participate in this ECHO, you are demonstrating that you have desire or potential for clinical leadership in your organization. It often helps if it's a hospital initiative. So right now, with the momentum through Ontario Health on delirium reduction and the hip implementation of the hip fracture quality standards, I'm hoping that this is going to catch the attention of hospital leadership and administration. And fracture liaison service coordinators were also highly recommended, and a lot of them are provided through the Ontario Osteoporosis Strategy. As we often see, the number of barriers is much higher than the number of facilitators when we have these surveys. And you can see all of the things there, not a hospital priority, not enough money, we don't have a champion, lack of coordination. And hopefully through the Echo Orthogeriatrics over the next couple of months, we'll be able to help you develop the knowledge and skills to be able to take it back to your own institutions to get the conversation started. So thank you very much for listening to that overview and introduction to hopefully what we're going to be talking about over the next few weeks. Does anybody have any questions? For either myself or anybody else on the team? Please don't be shy. Okay, great.
I think that was a good romp through orthogeriatrics, Jenny. Good.
There are lots of other areas if you want to learn more. I didn't put a slide up, but there is a really great organization called the Fragility Fracture Network that has been doing a lot of work on orthogeriatric care. And they're a great resource as well. They actually have an entire textbook, one on orthogeriatric care and also one on orthogeriatric nursing and one on nutrition that I would also be happy to share with everybody. Really great resources. Rebecca has her hand up.
Hi there. Thank you for sharing. I'm Rebecca Lemieux, a clinical nurse specialist in geriatrics at Mount Sinai Hospital, and we do have a orthogeriatric team here. My question to you is particularly related to delirium. The delirium rates with Victoria Hospital and University Hospital, how do you guys obtain your rates at 20.8% and 34.1%? Is it through the discharge abstract database, or do you use an alternative method?
We were actually using the National Surgical Quality Improvement Network to be able to get all of our data. So I'm going to put it out there. It may not be entirely accurate because it's going through NSQIP, but we're looking at like for like between the two hospitals because we have the same data collectors for both of them. So I think that's a really great point. I think that's something that we can leverage because right now I believe that joining NSQIP is voluntary, but my understanding is within the next year or so, Ontario Health are going to ask that all hospitals that have a certain volume of surgical patients will now be required to join NSQIP. So anybody who is not familiar, this NSQIP originated from the United States. It's the National Surgical Quality Improvement Network, aiming at quality improvement across surgical services. So one of their portfolios is hip fracture, and if you have Okay, I might let Celia talk about this in a minute because she probably knows a lot more about this than I do. But we do have a group of coders who will actually go through patient charts to be able to pull out information one by one, and that way we'll be able to see what the outcomes are over time. Celia, do you want to comment? Because I feel like you are able to tell me much more. Anybody with?
Yeah, thanks so much. I thought I would just kind of jump in. So this past fiscal year, they were kind of talking about it like about a year ago, and then they've started to onboard hospitals. They do pay a participant fee for you, like Ontario Health on Squin. So they weren't able to onboard every single hospital, but I believe they've committed to onboarding 10 this year. And so a lot in our region around London Health Sciences Center have like Chatham Kent, Blue Water, Windsor, I believe. And yeah, probably people on the call know more if they're onboarding or not. But I don't know if there's any questions specifically about NSQIP that I can answer for the group.
question. Does NISQIP use the ICD-10 codes similar to the discharge abstract database?
Yeah, so great question. The program is really focused actually more on the procedural code, and that's how they risk adjust. So they kind of lump them together and risk adjust that way. So CPT code is the American version of procedural codes. Here in Canada, we use CCI codes. You are correct. They still have to enter a diagnosis code, which is ICD-10. But in the States, it's CM, and Canada, there's CA. And so there's a slight variation, typically more with the ortho codes, but for the most part, it's pretty, for diagnosis-wise, interchangeable.
I found this really helpful because now, like, you can only move quality forward if you are collecting data. So if you don't know how your hospital or your patient population is doing, it's hard to be able to say how you can improve things. And I know this is one of the things that Ontario Health is looking into, and that's one of the areas that they're going to look into the e-reports as well. So I believe, I don't know if there's anybody from Ontario Health on here, but I believe that everybody is going to be able to see their own individual data, but won't necessarily be able to benchmark against other people. So for example, I can see what's happening in my hospital, but I wouldn't be able to say that, how is LHSC doing against St. Mike's? But I think that is a first step to be able to bring to your leadership areas that require change. And thank you for everybody who's putting resources into the chat. I think that's super helpful. Any other questions right now? Okay. If we don't have any other questions, perhaps we can stop recording.